Okay, good afternoon, everyone. Welcome to Endocrine Grand Rounds. It is my pleasure to introduce Dr. Emily Montgomery. Dr. Montgomery graduated from the University of Florida with a degree in biochemistry. She followed that up with going to the University of South Florida and getting her master's in medical sciences. Okay. And then she went to medical school in Granada at St. George's, and then she joined us as a resident at the University of Louisville and Norton Children's, and we had the pleasure of recruiting her to our fellowship program, and she is now our senior pediatric endocrinology fellow. And the most exciting thing that is happening to her this year is that she will join us as an assistant professor. As our new faculty member, as a clinician scientist. She has done a lot of research, actually, and then the second most exciting thing is she's getting married in just a few weeks. So the second most exciting thing. All right. So her along the way, she has done quite a few studies, mostly involving diabetes. And so that's really has been her passion. And so today she is going to speak to us on patterns of incidence and characteristics of youth with new-onset diabetes in the COVID era. So welcome, Dr. Montgomery.
Thank you, Dr. Winegers, for a very kind introduction. So I'm Emily, and I'm going to talk a little bit about what we have found here in our youth who have had new-onset diabetes in the last 6 to 7 years, and then just kind of look at what it's looked like in the globally and in the United States, and kind of some of the differences in patterns that we have seen. Feel free to stop me at any time if you have questions or want to talk about some of the graphs or things. I'm very excited about this. So I think it's really cool. It's also, I'm a nerd and I like diabetes stuff. So, you may think it's cool. You may be like, I've had enough of that. So I do not have any conflicts of interest. As far as objectives, we're really just going to kind of look at the rates of incidence, what the patient characteristics were like, the seasonal patterns of incidence for type 1 and type 2, looking pre-pandemic, during the pandemic, globally, as well as here. And then talk about the changes, what were the shifts in the incidence and the characteristics of our new patients diagnosed with diabetes during COVID, and how does that reflect our institute versus some of the other places around the world. And then we'll briefly talk about some of the hypotheses and a lot of the ideas that have come out about the underlying cause of this pretty significant change in incidence and shift in pattern of the way we're seeing new onset diabetes. So diabetes in youth during the pre-COVID era, this data is from the SEARCH study. And so what we see here is this is for type 1s, and this is about a 15 to 16 year period in the early 2000s into 2018, so just briefly before the pandemic. And so these purple boxes are the total incidence of type 1 diabetes, and it's rising at about 2% annually. But more significant than that, in the blue triangles, we see the non-Hispanic Black population increasing much more dramatically than the general population. And we also see the Native American population rising as well, not quite as dramatically as the non-Hispanic Black, but also more significantly than the other two. When we look at the male and female as well as age, we see that there's a little bit higher frequency in males compared to females, and that males have typically been diagnosed at a little bit of a later age compared to females. Females have been closer to like 10 years of age, and the males have been closer to about 14, but still in that early puberty kind of age where all the hormones are kind of raging. So we see a pretty consistent seasonal pattern of incidence in type 1. We can see here that January seems to really be one of the highest months of incidence, both in the early 2000s, which is the blue, leading into 2009, and in the red, it's pretty consistent here, as well as June being the lowest. We see a little bit of an increase over here in the spring and a little bit later on in here, but these seem to be really the key components to seeing that seasonal pattern. When we look at the type 2s in the same study, we also see an increase in the incidence of type 2 diabetes in the United States. We see a more significant increase. So again, we have the same variables here. So the purple boxes are the total population. And so we can see that this is rising a bit more and started at a lower rate than our type 1s did. we see that the same two populations, the non-Hispanic Black and the Native American populations, have the most dramatic increase in type 2 diabetes, just as they had the most dramatic increase in type 1. But this far exceeds the increase that we saw in type 1 in these populations. We also actually see an increase in the Asian Pacific Islander group that follows pretty closely with the purple group. We don't really see any change in the non-Hispanic white population, and the Hispanic population does increase, just not quite as dramatically as these two. So when we look at these two groups, the type 2 groups, we see that there are significantly more females than there are males being diagnosed during both periods of time, but they are at pretty much the same age. 16 years of age is like the most frequent age of diagnosis in both sexes for type 2 diabetes. And then the seasonal pattern is almost the opposite of what we saw for our kids with type 1, where we see August is consistently the highest rate of incidence. Whether this is because kids are being seen for well checks before school and they're catching type 2 diabetes on screening versus presenting much more frequently, our type 1s were presenting not at screening, more likely in DKA or other presentations and more so in the winter. And here we see that December is by far the lowest time of presentation for type 2, but you do see that the spring starts to increase pretty dramatically over the second decade. So just a quick brief review. So the change in incidence for type 1 is increasing at about 2% annually. Type 2 is more than double that at about 5.5% annually. Your peak age of incidence in type 1 is closer to 10. For type 2, it's closer to 16, so much further into puberty and closer to early adulthood. We see that the male to female ratio in type 1 is a little bit more in favor of the males, but doesn't have the same degree of difference that we see in type 2, where the females are substantially more frequently being diagnosed with type 2. And then the seasonal patterns are pretty much opposite. So we're seeing a much higher rate in the winter compared to the summer for type 1 and the opposite for type 2. So this carries on for a long time before and the first 20 years of the 2000s. And then we have COVID. And this seems to have created quite a dramatic shift in a lot of different parts of the way that we look at diabetes and the things that we've been seeing. So a brief reminder of a few years ago, we had our first COVID positive test in March of 2020 on the 6th. The World Health Organization declared a global pandemic on the 11th. We ran out of toilet paper in Jefferson County on the 14th. And everything started to close down on the 16th. We went to NTI. The 19th, work from home became pretty significant. And by the 23rd, all non-life sustaining businesses were closed. So we had a pretty dramatic level of shutdowns. And then in spring, we saw a decrease in clinic and outpatient visits, but we also saw a pretty significant decrease in non-COVID viral infections. I don't have the graph with me, but it basically plummets to zero and stays at zero through the entire spring for all of our typical URI stuff. We, different from the adult hospitals, had a decrease in pediatric hospital visits. People who came in were very, very, very sick. Nobody else came into the ED. So it was quiet or you were coding. There wasn't really a lot of in between in the middle of the night. And then we saw a pretty significant increase in pediatric mental health crises. Summer, things sort of opened up a little bit. The mask mandate happened. We continue to have really no non-COVID viral infections. School stays NTI. We work from home and we push the Kentucky Derby to September. Late 2020 into 2021, we got the COVID vaccine, so very exciting things happened. And we had pretty significant amount of COVID that we saw here in the wintertime, but the non-COVID viral infections still stayed at basically zero. And then spring and summer happened, so vaccination rates were increasing. Jefferson County schools went back into person in late spring. COVID infections dropped pretty significantly in the summertime related to vaccination and also being outside. Executive orders were removed for most COVID restrictions, and then we started to see a lot of the non-COVID viral infections were dramatically increasing and kind of cranking up. And then August 2021, I remember very distinctly because the hospital felt like it was on fire. It was wild. We had like winter in the summer with all kinds of respiratory stuff and also a ton of new onsets. And it was my first month of inpatient service as a fellow. And I was like, I just worked here 3 months ago and it was not like this. What is happening? And we were seeing not only a ton of new onsets, we saw more than one a day in August of 2021, but we also were seeing a lot more of this overlap. Is it type 1? Is it type 2? Like they're overweight or obese, but they don't have acanthosis, their C-peptide's not very high. Like what are we looking at and where do we think we're going at? It felt like we were doing that a lot more often. And so that's where the idea for this project came from. So one, what does the data show? Like, does what we're feeling, is that actually what's happening when we look at the numbers? Do we see the actual reflection? Yes, we're seeing a ton more than we used to see. Is there a difference in these kids that are being diagnosed during the pandemic? Why do we keep asking ourselves all the time, like, is it type 1? Is it type 2? Why are we seeing this? Is it different, or are we just seeing so many that we're kind of like, overwhelmed? Is this anywhere else? Is it just us, or do other people see this change? And if other people see it, what are they seeing and what are their thoughts about it? And then why? Why is this happening? So we went to the literature, and this has a little bit more now than was out back then. Back then, it really was, they talked about 2020 and the very beginnings of 2021, but there really wasn't a ton of data out there. Initially, so everything shut down in the spring pretty globally, and the rate of new onsets for everyone across the world dropped in the spring. But then there was a lot of conflicting reports. People like the UK were like, oh, we're having an outrageous number. And Germany was like, it's exactly the same. And then some other countries were like, it's totally different. Like, there was a lot of back and forth. But then after we got through the summer of 2020 and into the later 2020, into 2021, there's pretty universal. Everyone reported that they were seeing an increased incidence. There was some debate, depending on where you were, your institution location, how many patients you really had in your study. People did not always agree that the rate of the increase in incidence was greater than what was predicted based on what we were seeing before, where we were kind of expecting that 2% annual increase. Is what we're seeing dramatically different than that, or is it just that it feels like it's more compressed into a shorter period of time related to COVID? And then, some people were like, we're seeing all this severe DKA, and other people were like, it's exactly the same that it was before. And so there was a lot of back and forth. Nobody could really make a strong decision. Europe did report the same shift in the incidence that we saw, where 2020 was pretty low earlier on in the year and then picked up later. But most of the papers talking about the European seasonal pattern showed that they actually went right back to their normal pattern that they had had previously in 2021. Germany and the US did not have that return. We actually stayed in that same seasonal pattern where things were moved and the spring wasn't as a high rate of incidence as it was before. And then there wasn't any data for 2022. Patient characteristics also up for debate. It depends on where you are, how many people were in your study, was there a difference in the ratio of sex, the age, did it go up, down, BMI percentile, A1C, all of that's kind of up for grabs. For type 2 diabetes, there is very little data looking at this. And of what has come out, it's almost entirely from the United States and like 1 or 2 studies from Germany. And everyone reports a significant increase in type 2 incidence during the COVID times. And everyone also agrees it is greater than predicted. It was definitely more than 5% increase per year. They're saying variable reports. Are we having a higher rate of severity at presentation? Does it look the same? It depends on who you ask. In the United States, we saw a much higher rate of obesity during the pandemic. And part of the concern about this is that the shift actually occurred in the younger group. So the 9 to 15-year-olds saw a much more dramatic increase in obesity than the older kids, who are typically the part of our youth that have obesity. And then patient characteristics, the same. Socioeconomic status, some people said they were seeing a higher rate in a more disadvantaged population. Other people in North Carolina, they said, no, like we're seeing that they're more likely to have private insurance now. The kids are being diagnosed with type 2. And so it seemed to be very location dependent, like Alabama versus LA versus DC. Everybody kind of had a different idea. So about both of them together, there's a lot of why, right? Like nobody can really kind of pinpoint what it is that's underlying this. A lot of hypotheses are thrown out there. There's definitely not an agreement. we know for sure that there are several different factors that contribute to this, and we'll talk about that a little bit, but there's definitely not a clear-cut mechanism. And then what happened after 2021? The data available at that time really ended in early 2021, and now it goes through early 2022, but there was nothing about what happened in 2022. Did we continue to see more, a higher rate of incidence? Did we continue to have the shift? Like, what does that look like, and how is it continuing in the future now that, we've kind of moved out of some of COVID components? So the research plan briefly was just to determine the incidence of diabetes subtypes here at our institution 3 years before COVID, 3 years during COVID, look at the seasonality, look at the pattern of incidence, looking at those 2 times, and then also looking within the time of the pandemic, looking at 2020 versus 21 versus 22. Doing the same for type of diabetes, antibody profiles, the difference in characteristics, both looking in both of those periods, and then evaluating the regional trends, as well as specifically evaluating the association of socioeconomic deprivation and the incidence of diabetes. To be included, you had to be a human, you had to be 1 to 21 years of age, and you had to have your diagnosis here or at least your new onset care here. This was between January 1st of 2017 and December 31st of 22. Patients who were excluded did not meet diagnostic criteria. They had another underlying cause of their diabetes, they had MODY, or they did not receive their new onset care here. So a couple definitions. I use the ISPAD criteria to define DKA, HHS mixed and their associated severities. The social vulnerability index is something that we use to kind of give a better idea of socioeconomic status and vulnerability and risk, because it has a lot more factors that it combines into the score. So it evaluates for factors that determine a community's ability to prevent human suffering and financial loss in a disaster, both a natural disaster or a infectious disease outbreak, which seems very fitting for this. So 16 total factors, and they are like socioeconomic status, but it has education, who lives in your house, how many generations, are there disabilities, do you speak, the language in your area, all the different things that really are important features in determining people's risk and vulnerability as part of the population. And then we use census tracts for all of our different patients to determine these different things. So there were 1,139 charts, 969 patients were included. There were 408 new diagnoses before COVID and 561 during COVID, for an increase in 38%. We did not, because there were a limited supply of testing materials and other things, there was a large period of time where we did not get to test for COVID at the pediatric hospital. And so there is a very small population of patients diagnosed during that time that actually had testing. Only about 100 were tested, and of those 8 were positive. So this is just kind of a brief view, and we'll go into this, but you can see, so here is the beginnings of the COVID, and you can see that this definitely is trending up some more and kind of levels out here at the end. But this is the overall, the blue is like the actual monthly incidence rate, and then the green is a trend that kind of gives you a better idea of where we were headed and where we went. So for type 1, we saw 361 diagnoses before COVID and 402 during COVID, which is an increase of 11%, which was significant. And you can see that we kind of dropped here and then we came back up, and we actually kind of peaked right around here and then continued and stabilized out later here. So looking at our population, we didn't see any changes. We had a little bit higher rate of males than females, but it wasn't different before and after. The race was unchanged. The age groups were unchanged. C-peptide looked the same. But there was a statistically significant change in BMI percentile, which goes along with the pretty significant increase in obesity in the general population, in that we actually had an increase of the median BMI percentile for our new onset type 1s. Household income, social vulnerability related factors, and education were not significantly different. So here just gives you a little bit of a visual looking at the significance of the increase in the BMI percentile. We definitely got a lot closer to kind of your the bottom of our overweight category here, and we had a much higher number for the bottom of our group. And then severity at presentation, the overall rate of DKA at the time of diagnosis was unchanged, but of those who presented in DKA, they were much, much more frequently in severe DKA at that time. So there was a much smaller number of people who actually had mild DKA at presentation. And then here, this looks at the antibody profiles. So you can see here so up here is like the actual profile. So if you were like triple positive, if you were GAD-NIA2, GAD-NIA, GAD only, et cetera, or you had no antibodies. So the GAD-NIA2 dropped from 40% to 34%, which was significant. And a compensatory increase is seen in the GAD insulin antibody and then the GAD by itself. And so when we looked, we took out everyone that had a GAD positive, regardless of like how many other antibodies were also positive. We saw that this is actually driven by a decrease in the IA2. There was an almost 10% decrease in the positivity of IA2 in our type 1s during the pandemic, which is interesting. And I don't know why yet, but I am reading a little bit about it. And nobody has really reported this yet. And then when we looked at Hashimoto's and celiac, we actually saw a difference as well. So for Hashimoto's, we had almost 20%. We had 18.7% positivity before the pandemic, and that dropped to 14%. And then for celiac, it almost doubled. It went from 5.9% positivity to 10.1%, which was statistically significant. Why? I do not know. And then when we looked at our seasonal pattern, this is before we had COVID here with us. So you can see we're higher in the winter and the fall up here as our peaks. And then the trough is always in the summer. And when COVID came, that changed everything quite significantly. So you can see that we are having our peaks at very opposite times to our troughs. So here's summer of 2020, summer of 2021, and summer of 2022. They're quite significantly higher, and then fall and winter were lower in all of this time. So when we looked at the antibody positive type 1 versus antibody negative type 1, it's interesting to see. So the blue is pre-pandemic, and you can see that there's always been a pretty significant peak in incidence of antibody negative type 1s during the summer. And so that their incidence pattern actually didn't change almost at all versus your antibody positive type 1s. We saw almost none in the summertime, and it changed to be the most frequent in the summertime. So a quick summary of our type 1s, the incidence increased by 11%. The BMI percentile went up. The age did not change. The positivity of IA2 dropped by almost 10%. Hashimoto's went down, celiac went up, and summer became a very popular time to be diagnosed with type 1 diabetes. So looking at type 2, we have same graph here. So we can see that we had a pretty low rate of incidence that dramatically increased here. So we had 47 in the 3 years before COVID and 159 during COVID for an increase of 238%, which does exceed the 5% increase annual that we were seeing before the pandemic. So when we look at this population, we see a couple of things. One, the age group dropped dramatically. So typically we have seen like 60+% of our people have been 15 or older. And during the pandemic, 50% of them were less than 15, which is very concerning, right? Because the earlier we start with these complications, the harder it's going to be in the future. So more than 50% of them were 11 to 15, with a big drop in the number that were older than 15. And we actually saw almost 10% were between 9 and 11. As far as race goes, it's not statistically significant, but I do think it's interesting. Previously, it was evenly split, 40% non-Hispanic white, 40% non-Hispanic Black, and then 5% Hispanic, with anybody that had more than two races we combined in one category. But during COVID, we saw a shift. So the non-Hispanic whites dropped to 25%. The non-Hispanic Black population went up almost 10%, and the Hispanic population went up 5%. So you saw definitely a shift of things changing. So it's definitely not equally distributed anymore. And then when we looked at the social vulnerability and education, the social vulnerability does not technically change, and it's not statistically significant, but there is a shift in education in that the people diagnosed during the pandemic lived in communities that had higher levels of education. So there were less people that didn't make it through 9th grade and more people that had associate's, bachelor's, or professional degrees. So here is just a graphic to show there's the difference in age at diagnosis, and it is pretty high up here, and now we're hanging out way lower here. So for our population, the percentage of patients who did not have DKA or HHS at presentation was about the same. It was 86% before and 87% during. But there was a little bit of a higher rate of mixed DKA HHS during the COVID time, with about 7% compared to 2%. And 7% of 160 is a lot more than 2% of 40. So we felt the difference more significantly than the numbers actually showed. As far as the seasonal pattern for type 2, we did not have enough type 2s diagnosed before COVID to really establish a firm, true seasonal pattern, but this is kind of what it looked like, where you can see there's all different months that are peaks because we just didn't have that many. And then after COVID, it has a little bit more pattern. So summer to fall was pretty high here, summer is pretty high here, and then winter to summer here. So a summary of our type 2s, the incidence went up a lot, 238%. They were younger. Their BMI did not actually change. It's just that they were getting to that BMI of their cohort faster than the kids had years before. The educational background actually was higher achievement, and a seasonal pattern was like sort of established, but not super consistently. So when we look at the overall incidence trend of our population for all three, you can see, so the green here, the solid line is all types of diabetes. The orange dotted line is type 2 or type 1, and the blue dashes are type 2. And so you can see we kind of had a bump in 2018-ish with our type 1s. Our type 2s stayed kind of steady, and then everything changes right here. So you can see we went up for all of these, but we peaked, which is really interesting. And it's actually not been reported before that everything peaked in like spring to summer of 2021. And then it came back down for like the following year into summer 2022. And then it just stayed steady. So it'll be interesting to see what 2023 looks like, because I don't know that we had anticipated it would come down so significantly during 2022. But I am very pleased that it came back down because we were having a lot of new onsets at that time. So just kind of going over the things that we've talked about, the things that are in the literature and kind of how these things line up. So our 3-year increase is a little bit higher than the predicted annual increase, but is it dramatically so? Not so much. I don't think that's what drove. It's not clear that COVID substantially drove the change in type 1 incidence, but it does seem that the type 2 incidence may have been a little bit more affected because our 3-year increase is a lot more than the predicted annual increase was. So looking at seasonal patterns for type 1, the general population was winter all the time, never summer. Our population actually was fall all the time, very rarely summer. We weren't super into the winter diagnoses. Type 2 was generally always in August and like least in winter. And then everyone was summer during COVID. So in Europe, they were summer. Our population was summer. Europe in 2021 went back to winter much more frequently than summer, but our population and Germany's population stayed the same. And then we have shown that in 2022, it was consistently having the highest rate of incidence in summer. As for type 2s, we previously saw the highest population or highest rate of diagnosis was in like August, which is late summer, and it stayed to be summer throughout the pandemic. So everybody has a different idea of severity at the time of diagnosis, and some of the countries are double dipping. So like France says yes and no, depending on who you ask. Greece did the same. Spain said no early on. Alabama said no, but like North Carolina and Washington, D.C. and LA said yes. Turkey, Poland, Israel, Italy, Romania, Finland, Brazil, Portugal, Canada, Germany, and Egypt all said yes, that they feel that it has been pretty significantly increased. As far as socioeconomic status, so for us, we saw consistent with what's been reported for years is that our type 2s had a more disadvantaged background and community education and vulnerability index than our type 1s, but not super significantly, and it really didn't change during the pandemic. We did see that there were no changes for within the type 1, but the type 2s came from a higher area of education. So this is just a reminder that things went up a lot so that we can go to the next slide. It's our transition into reminding you that we had a lot of diabetes during COVID. So why is this happening? And this is where things kind of get interesting. So there are reports that the virus can infect the pancreas. But what cells actually produce the ACE2 receptors that it infects effectively is up for debate. Is it the like ductal microvasculature that's near the islet, or is it actually cells within the islet? And if it's within the islet, which cells does it actually affect like pretty significantly? It is also very widely debated if there really is true potential for direct viral destruction of the beta cells, even if it can access inside the islet. But there is pretty wide agreement that there have been indirect effects of viral infection, which are causing issues with the immunologic activity, worsening immune cell invasion in like encephalitis, and creating a much more rapid loss of beta cells in those who are predisposed to developing diabetes. But the mechanism is still very, very unclear. And then it gets more complicated because it turns out all the studies around the world that actually evaluated for COVID infection at the time of diagnosis or prior to diagnosis showed that almost nobody that was diagnosed with diabetes during the pandemic had a COVID infection in our pediatric population. So even if the virus can infect the pancreas, almost none of these kids were infected. So for them, what is the driving force? Because if you're not infected, you obviously can't have like a viral attack on the pancreas. So our population, we had very few people who we tested, so we couldn't really speak to this. But we can see that like all of these theories exist, but you have to have infection. So what else is playing a role? Because most of these kids were not infected. And so there's a lot of thought about there being some immunologic and also metabolic effects of stress, both physiologic and psychological stress related to the drastic environmental changes we had with our total like shutdown of and social isolation, and whether or not this actually increased some of the immunologic processes and also some insulin resistance. And so we know that the lockdown created more social isolation, and it also created decreased physical activity and an increase in sedentary lifestyle, both in those who were active in played sports and those whose activity really came out of like being at school and walking the stairs and the hallways and the bus stop and things like that. So the start of virtual school really kind of disrupted that. And this loss of structured environments, I think, is probably the biggest component, right? Like parents had to work, kids were supposed to do school during the day, like on their computers. A lot of parents didn't get to work from home. And so like the kids were either staying up all night and like sleeping all day, or they were like raiding the pantry all day while they were doing NTI, and there wasn't a lot of structure. Like at school, you like go to lunch, but you don't have like access to food all day in class. And so that seemed to create some issues. We saw a dramatic increase in obesity. We talked about the highest rates actually occurred between the 5 and 15-year-olds. So we went down pretty far into like kindergarten with obesity, which is of grave concern, I think. And so did this increase in obesity, psychological and physiologic stress, sedentary lifestyle, and decrease in physical activity, did this push people over the edge? Did this create a worsening of insulin resistance in those at risk for developing type 2, and also for those who or maybe like limping along, had some insulinopenia, but not so significant that they had presented in full diabetes? So our population, we did see some things that would support this, and that our type 1s had a higher BMI percentile, and we did see a few of them that had acanthosis anecdotally, and our type 2s were a lot younger with a highest rate between like 10 and 15, which both kind of fit this pattern that we saw. And so looking at our trend, we had kids went back to school in 2021. Our peak was in spring 2021, and then things kind of started to go back to normal in summer of 2021. So are those related? Like, is the fact that we went back to more structured environments and we didn't have the same degree of social isolation, is that part of why we started to see an improvement in the incidence rates? Or is it something totally different that we have not evaluated and have not yet looked at? I don't know, but I think it's really interesting that, we saw this dramatic decline. We had a year of like pretty significant incline, and then another year of decline. And now we've kind of stabilized out as things have been kind of unchanged regarding social isolation and being in school and structured environments. So I think it'll be really interesting to see what 2023 looks like. I can tell you for sure that 2024, February has been very popular. We had 15 new onsets in the last week and a half. So I think that one is going to be a big month for 2024. So we'll see what the pattern looks like now. But it's interesting to kind of look and see what were the different things happening around the world that happened during this time. So this is just what I basically just said. But so it'll be interesting to see kind of how things how things look. So this is just my summary of the things we've talked about. So things shifted, summer became very popular, there was a lot more diabetes, and why we definitely don't know. So this is just things we're looking at 2023, looking at all the viral patterns, which are very interesting, and show a substantial decrease in viral infections that were not COVID, except for rhino-entero kind of still did its thing, and continuing to investigate autoantibody patterns. I read a lot of papers when I did this, and I'd like to say thanks to Dr. Watson, who has carried me through this, and Dr. Kahir Jawad, who is our data analysis guru, as well as my SOC group. So here's your CME code, and I'll take any questions, thoughts, comments.
And you showed this a higher, rise in the not less than non-Hispanic whites and more in African Americans. Did that, I know in the local group you had interracial, biracial, did the African American and the Hispanic, did they have interracial sort of being looked at, or was it just reported, whatever was reported as the race?
So we have like all of the different reported races. So like if there were multiple races, we put them in a 2 or more races category. Is that what you mean? Yeah.
But in the national, they didn't have.
They did not. I think that I don't know if they excluded that group or if they just forced them to pick one. Yeah.
Comes with diabetes, and we had some interesting sort of observations. So I was wondering, you had mentioned they didn't get tested as much early on, and then later we found that those were diabetic, were not necessarily COVID positive.
So the people who reported, so here at our institution, we did not have the supplies. They were redirected to do some other things, but the studies globally did have supplies and did test early on and through like 2020 into 2021. So they had testing early on.
Like we saw vaccine related thyroiditis or some other VT, see anything related to vaccines, the diabetes?
A few people reported very small amounts about vaccines, but nothing was statistically significant. And I think honestly, it's because of the timing of the information that came out. There's not been a lot that's come out about 2022, and what came out last year was very much about earlier in 2021, and they just didn't have a lot of that information.
Is it because other people have not reported, other people have still continued?
Nobody has reported on 2022 incidents like changing.
Don't know.
Yeah.
And what about, subsequently, in terms of in their columns? Did they behave the same as before, in terms of, was it easier to control them or so they have any?
I have not looked at that data specifically. There's a lot of them, but I have not seen anything significant where we were having, there's not been anything obvious that anyone has brought up about, we're having different difficulties or differences in the way that we manage these kids. They've been pretty much the same as before, just that we've had a greater overlap in that area of like type 1 and type 2.
Yeah.
So I would just add to that would be difficult for us to look at because there are newer drugs available that are going to overlap with this time frame, because we got GLP-1 agonists for kids right before the pandemic. right? So how we treat type 2 diabetes is kind of fundamentally changed. We have multiple drugs we can use now versus just insulin and metformin.
Perhaps for type 1, it would still take a significant amount of effort, but try and look at the insulin requirements, by body weight or whatever we would want to do it, and try to see if there's any comparable difference over time. Did the remaining beta cell mass that we typically see for a short period, honeymoon period, was it different? Again, that's the nuances. It would be really hard.
Yeah,
to
especially with the
do
hybrid
that,
post,
but
right?
So is there any
Yeah.
hypothesis about why the IA groups go more?
No, but I'm going to do a lot of thinking and a little bit more reading about it. I just figured that out like a week or so ago. C-peptides are unchanged between the population. Yeah, C-peptide and the A1C were, there was no statistical significance between the C-peptides and A1Cs.
You notice that for type 2, because they are high jump.
Yeah.
You go back and see whether the patient have exposed to the steroid, but sometimes
So we did not
Sometimes the
include,
even with the upper respiratory tract, especially in the beginning of the COVID, they give steroid for everyone.
yeah, so we did not include anyone that had steroid-induced hyperglycemia. That was an automatic exclusion criteria. Yes. I excluded everyone with cystic fibrosis or any other medical condition-induced diabetes. There are a couple of kids who had prediabetes that was noted, but I don't know that we did a fabulous job of screening kids for type 2 diabetes like 6 years ago. So, but most of the people that are in this study also presented to the hospital and had A1Cs that were higher than 9 for the majority across the board. Dr. Thrasher has been putting his hand up a lot. Yes.
Thank you.
My pleasure. Yes.
So, you showed an 11% increase in type 1, which is crazy huge, right? We all felt it. Did you look at any data looking at other autoimmune diseases like Hashimoto's or celiac to see if there's an increased rate in those particular
I have not seen anything. I have looked at a few things. I've not seen any of those were dramatically different by themselves. We saw some different trends with our own population. Hashimoto's was less frequently seen, which has been reported by a couple of groups in Europe that they also saw a decrease in Hashimoto's and an increase in celiac in their type 1s. But nobody has really reported that I've read, at least outside of the diabetes new-onset population, looking at that. That's a very good question.
Any differences in the other features of metabolic syndrome?
No, nothing that everybody doesn't get lipids initially, but there's nothing like substantial that kind of stood out.
So it looks then like a very specific glucose-related effect, not more general effect of weight or stress with a permanent effect on everything else.
Right.
No? So this is more glucose specific.
It seems that way. I think we've seen what we kind of generally see in that population with an increase, typically they have a higher cholesterol in our kids that have type 2. So I don't think that was substantially different. It was still high, but it wasn't significantly different from what we saw before COVID. Yeah. So just that they're reaching it at an earlier age. There are no questions in the chat. Yeah. Dr. Folsom. Yes.
Really good of the data that you found, and I think really good acceptance of some of the unknowns and some of the bias. You found that in our population, the antibody positive type 1 diagnoses and antibody negative type 1 diagnoses were different. How did you define antibody negative type 1?
They had to have a low C-peptide, no evidence of acanthosis or any other evidence of insulin resistance, and had to otherwise meet type 1 related criteria. So there are only about 36 and it's 36 and 37, I think, for the type 1s who were antibody negative. And there is not a difference between them, like for the antibody negatives between the two periods. And there's not a huge difference between the antibody positive and the antibody negatives either. Mhm. There is, and there's a known like 10-ish% of people with type 1 are antibody negative, so it's not super far off what we would expect for that, but it is an interesting group. And their C-peptide was like less than 0.5, and like they had, they didn't have any exciting characteristics. I did look at that and compare them to antibody positive. None of these kids had ZNT8s that were run before I started, so like in the last 2 years, but I did look for ZNT8 in everyone. I looked for ZNT8 testing in everyone, but I also looked in like 2021. And I know some of them have had ZNT8 testing since then that has been positive. So it would be helpful to have that data, but we have not routinely collected that. I think that would change some of our antibody status data. Most of them are, but they all like are ketotic, and have had low C-peptides and are typically, I don't think any of them have a very high BMI. They've all been lower on the BMI and no acanthosis. Right. No, we've not had any of those. Yeah. No, they've all had very low C-peptides. Well, thanks everyone for listening.